You're listening to the Physio Matters Podcast in association with Choose Health, and this is session 7. Welcome back to the Physio Matters Podcast and to a landmark session 7. The landmark is a 6-month anniversary for the podcast, and we've secured interviews, sponsors and supporters to continue monthly podcasts indefinitely. I'd like to personally thank the previous 4 podcast guests, Dr. Lee Harrington, Dr. Ian Horsley, Mike Stewart and of course last month's Seth O'Neill. All I do is put microphones in front of them and I fight the urge to nod along in awe, so thank you very much to them. Seth's interview on session 6 has smashed all of our records and created an influx of new listeners and subscribers, so many thanks once again to him, and of course to all of those of you offering feedback and reviews. It's much appreciated. We went on about it a lot last session in session 6, and so we stand by it today. The growing body of physios on Twitter has resulted on it becoming an invaluable CPD resource. As a way of me putting the podcast under a few noses back in December, I ventured tentatively onto Twitter and was immediately made aware of today's podcast guest. Adam Meakins is an increasingly eminent name in the industry who is known for opinionated honesty, myth-busting and therefore some controversy. It wasn't long after the launch of sessions 1 and 2 that we asked listeners, subscribers and Twitter followers who they wanted to hear more from, and Adam's name was consistently pushed towards me. Rather than discussing his clinical special interest, which is the shoulder, we've decided to use this episode to call Adam out on a few topics such as Twitter as CPD medium, critical thinking in physiotherapy, and a favourite of mine, the misconceptions around passive assessment and treatment techniques. I caught up with Adam following his lecture at the Undergraduate Sports and Exercise Medicine Conference, which he was talking at last month, and I hope you enjoy our chat. So let's get to it. Adam Meakins, welcome to the show. Do you want to introduce yourself for the listeners?
Yeah, sure. Thank you very much, Jack, for giving me an opportunity to speak and get on your podcast, which I'm very much looking forward to.
My name's Adam Meakins, and obviously I'm a physio, hence the reason I'm being interviewed on a Physio Matters podcast. I've been a physio now for coming just over 10 years, graduated in 2003, but I haven't always been one. I entered the world of physiotherapy a little bit late. What they classed as a mature student, although I was anything but mature, and I still probably am anything but mature now. I started my working life in personal training, moved into strength and conditioning, did a diploma back in 1999, worked in that for a year before I managed to blag my way onto a physiotherapy course at the University of Hertfordshire in 2000. And that's me in a nutshell. I had a fairly typical career, like most physiotherapists. I started off working in the NHS for a few years, moved into private practice, doing a few jobs on the sideline, working for various local sports clubs. And in 2007, started to specialise in the management and treatment of shoulder under the guidance of an excellent orthopaedic consultant I work still very closely with at Spire Bushy Hospital, Mr. Simon Lambert. And then in 2009, I was fortunate enough to get a position working for Watford Football Club for 3 seasons and sort of develop my skills working with professional sports people there. And that's what I still continue to do now, working back in the sports industry with Spire Bushy Hospital for their sports and exercise medicine department, which they've called Perform, where again I still specialise in treatment of the shoulder there as well. And I guess I'm also known by some under my pseudonym, some will say my alter ego, that I've created rather pompously online called the Sports Physio. And that has somehow, although I'm still not quite sure how, managed to develop a following online via Twitter. And that's me.
And so you, as you mentioned, you're best known under your Twitter alias as the Sports Physio. How did you develop an internet following?
Yeah, this is a good question, and I wish I had a good answer for you, but I haven't. It's a bit of a strange one, and it did take me by surprise. As I keep telling people that no one else is more surprised that people actually want to listen to me than I am myself. I don't know is the simple answer. I think, as I say, the Sports Physio is one that I put on there, and it is a bit of a pompous sort of title. And say after interacting with loads of people on Twitter, there are a lot more people that could call themselves the Sports Physio. I obviously had experience of working in sports and being a sportsman myself. But when it comes to, giving myself a title, the sports physio seemed to fit the best. And I think people obviously, search for something when it comes to, they've got an injury, they'll look for somebody online and they'll go for the sports physio. So I think I obviously appeal to a wide spectrum of people. And then I think there's also the side that has developed a following because of a bit of controversy that I like to do on a regular basis, and probably a bit too regular, if I'm being honest as well.
And we'll soon talk about that, definitely. But why Twitter? It's the world of celebrity gossip. Sometimes sales and marketing gets in there. So what brought you to Twitter for CPD reasons?
Well, it was, first of all, it was just a little bit of curiosity. I mean, when I first thought of Twitter, I thought it was just for the likes of Justin Bieber's, people that put on what they had for breakfast and stuff along those lines. And I got on it quite early and I had a look around, and that's pretty much all I saw on there. And this was like a couple of years ago. And then I thought, I sort of fell off it. I didn't do much on there. And then I sort of reactivated the account and I started looking around and I thought, what could this be used for? So I decided, I'm going to try and see if I can get some information out of it. So I started searching. I found a couple of other, people that are on there, useful people. And as I say, there's a few influences that sort of got me going, thinking, this is a good thing. This is where, we can get some good sharing of information. We could get some collaboration, and we could sort of use it as a learning tool. I mean, one of the biggest sort of influences, I think, and I don't want to drop too many names in the interview, but I mean, there was a guy called Tom Goom. He was like one of the first physios, I think, that I sort of interacted with on Twitter a couple of years ago. And I saw that he had a blog page and he was putting out information and he was helping runners. So Tom Goom, obviously, is known as the running physio, and he's got an excellent webpage. And interacting with him, he sort of gave me this sort of light bulb moment. I thought, oh, hold on a minute, this could be something good for physiotherapists in general. So that's how I got involved in it, and I started doing the same thing. I got myself a blog page, started writing out there, and then started throwing out some evidence and some papers and sharing it. And I think there's a lot of people out there that are hungry for information that want to use it. And that's what I use it for.
Lovely. And at 11,500 followers and counting, that's my last check, as far as I can tell, you're the most followed physio on Twitter. If I compared your popularity to another industry, some would say Lady Gaga had moved from one controversy to the next in order to sort of stir the pot and make sure people are constantly talking about it. Are you physio's Lady Gaga?
Well, not following Lady Gaga, as I'm probably sure that you do then, Jack. So I can't actually say, because
you caught me out there.
I mean, do you follow Justin Bieber as well? Does he do the same thing?
Avidly, mate. Avidly.
No, it's a good point. Yes, is the simple answer. I think creating controversy does create good, honest debate. It does allow us to sort of a platform to start to discuss things out there. So yes, I think I am guilty of that. I do create controversy. Yeah, to gain followers, I suppose. But I've got no commercial interest in gaining followers. I'd say it is nice to be felt like I am looked at by people. There is that sort of bit of an ego side of it from my perspective, but it is very small. I mean, the main reason I do this is to try and, I think, disseminate information, dispel some common myths and misconceptions, and if I'm being honest, trying to drag the physiotherapy profession into the 21st century.
Mm-hmm. Okay, and we will certainly come to that critical thinking element of things later in the interview. But sticking with Twitter for now, what would you say are the key pros and cons of Twitter as a professional interface?
Well, the main pro, I think, is being able to gain immediate real-time access to some of the world's leading experts in all fields within and around physiotherapy, and being able to network with them as well. That is a massive, massive bonus. I mean, you can go to some of these conferences and courses and hear these experts talk for 20 minutes, but then, you don't get access to ask them the question you wanted to. You don't get the time to actually, chat to them about various different things. On Twitter, you can do. It's also good, I think, as I say, of a way of making sure that you get different views and opinions as well, because there's everybody on there that has various different views and opinions, and it's good to listen to those and to see those. So it gives you access to that. Now, obviously, you can sort of block and filter out things on Twitter, so you can still be guided by your own biases. But if you're open and you sort of follow the people that have, different views from things, I think it's a definite pro and a definite use that Twitter does. The cons, obviously, there's limitations because of the limitation of the letter count. You can only get so much information across in a short period of time. And that does produce some issues with regards to miscommunication. I've been on both sides of the story with regards to that. And it also, I think, sometimes polarises people's opinions. So we get a lot of sort of debates and sometimes disagreements and even arguments purely because of misinformation, and then it polarising an opinion into a yes or no answer when sometimes it's not that simple. But because of the limitations of Twitter, it produces that. And then the other con is that you just get some idiots on there that will just want to try and promote a reaction or just say a comment out and try and see if they can, make you bite and nibble, which unfortunately I have been guilty of on a couple of times as well.
Okay, and so the obvious one is the brevity, the 140 characters that people feel sometimes stifled by, and hopefully we can give more of a voice than Twitter can today. But would you say that suits you as a person and the way in which you want to and like to express yourself?
Absolutely. I've got an attention span of a goldfish. In fact, I've probably forgotten who are we, where are we? No. But yeah, no, it is good to say short, sharp bursts of information, I think, are definitely the way forward. It's a death by PowerPoint and reading papers and lectures and everything along those lines. You only gain so much information. And being able to pick and choose where and when you want to take that information in short bite-sized pieces is definitely, again, a plus factor for Twitter. Yeah.
Lovely. And since you first began using Twitter as a professional, what dramas have you found yourself encountering?
Where to start? I mean, we could probably carry on, for another couple of hours. I've had my fair share. I think probably the most famous one and the one that kicked off probably a lot of people following me was the Psoas-release-gate affair that happened. So this is
I think that's before my time, so enlighten me.
Yeah, it was a good year, 18 months ago, I guess now, but there was some comments on Twitter about people having this soft tissue technique called psoas release, which I've written a blog on. But basically they palpate deep down through the abdomen in a belief that they're actually trying to get onto the psoas and release it, whatever release means. And I just managed to put a little off the quip mark about psoas release, the fact that, one, you can't palpate it, and two, what the bloody hell you're pressing down that hard through the abdomen for anyway? What's your clinical reasoning behind that? And then that created a backlash. A lot of therapists and people decided, who was I to critique this and everything along this line. And it even got to the point where there was some sports therapists who thought they could take legal action against me, and they say they was threatened with that. So I'd say through my employers and things along those lines, it all just got a little bit heated. So that was a learning curve, and that was sort of the main big one that I've had. There's been others as well. As I say, my use of Twitter to promote an evidence-based thinking approach and doing things means that I'm always going to upset people. And, I've upset acupuncturists, I've upset dry needlers, I've upset manual therapists, I've upset institutions and stuff along those lines, purely because I am expressing an opinion that is different from theirs. So that is probably one of the main sort of drawbacks, as mentioned, with Twitter.
And is it water off a duck's back when these things happen, or do these things rattle you, or do they affect you? Do you roll with it and learn from it?
They do rattle me, yeah, definitely. I'm human, as I say. When people do have a go at you and start, sometimes being quite aggressive and sort of personal about it as well, you can't just let it go over your head. You try to, and there's sometimes I do, but no, there is issues there that do make me think, why do I bother? And I've had a couple of moments like that where I thought, I'm just going to shut down Twitter. I can't be bothered with this. It is too much hassle sometimes than it's worth. But then you got to think and say the bigger picture, and I still say I'm quite keen to try and promote, an evidence-based critical thinking approach to everybody in all this musculoskeletal industry. So I will stick at it and I'll keep plugging away. I think I've now got a thicker skin because of it, and I've learned how to handle it better and learn how to deal with it. So it has been a learning experience, and I think I'm not as guilty as making as many mistakes as I used to.
Yeah, and that brings me nicely on to my next question. Having met you, I can see fundamentally you mean well. However, do you have any regrets on specific things even?
Absolutely. I mean, as I say, debate and being able to debate logically is a skill, and it is one that I am getting better at. But I have been guilty of making some logical fallacies. I have been guilty of falling into traps and letting emotion take over rather than being reasoned and sensible about it. And one that sticks in my mind was a debate that I had with a guy who was a sports scientist, and we're talking about pre-match warm-up routines. And you look at the research, there's no evidence one way or the other. You can argue till you're blue in the teeth. And I ended up making the mistake of giving him, one option or the other. If you think this, then you're that. If you think this, then you're that. And that's not the way to debate, because, as I say, there's no, two answers to most things. There's always a middle answer, a third option, which is usually the middle ground. So I made that mistake and say I definitely have learned from that. And, there's been others as well, but that's the one that sticks in my mind.
No, that's great. And for those that might still be lurking on the outskirts, what would you say to the top tips-wise for people that wanting to immerse themselves into Twitter? Do they need to get stuck in straight away, or can they hang back?
I think it depends on the type of person that you are. I think, everybody's different. Everybody's, introverted or extroverted to a certain extent. And I think that's the beauty of Twitter. You can be either or. I think you do gain more from it if you do interact. I do think you get more out of it if you participate. But if you're the type of person that does get upset easily, or you can, find yourself a little bit shy, then you might not want to. You might just want to listen and learn from other people from afar. So I think there's both. I think my top tips would be to, be succinct, have an opinion. Don't be afraid of having an opinion, but be honest with it as well. Don't just try to tell or say things that you think other people want to hear. Be true to yourself. Be respectful, and as I said, learn how to debate logically. Don't fall into the regular fallacies that a lot of people do when we are discussing things which sometimes don't have a definite answer.
As we've already discussed, one of your key goals is to provoke critical thinking and inspire that into the industry. But for it to be a goal, I assume you think it's lacking?
I think it's lacking in some. I don't think it's lacking in everybody. There are some excellent critical thinkers out there, and some that have inspired and got me better at it. But yes, in general, critical thinking within the musculoskeletal medicine, sports therapy, physiotherapy world is lacking by most. I think it's a tendency for a lot of therapists to just get comfortable. They learn something, they see something that works, they're happy just to sit back and carry on doing that without asking the why question. And we need to be constantly asking why. And I understand why it can be comfortable not to have to keep asking the why, because it does get uncomfortable. I have a little saying that say, if you're working in this line of work, you've got to be comfortable with being uncomfortable, because there are sort of no definitive answers. As soon as you think you've got the answer, you're wrong. You've got to keep constantly critically thinking and analysing what you're doing. And I think that's a skill that not many in practicing physiotherapy do. I don't think it's taught that well either as well at an undergrad level. I think a lot of therapy universities try their best. I know that they're stuck with time limitations, etc. But, a little bit more work and emphasis on the fact that, you need to be able to critically evaluate evidence and critically think for themselves and not be afraid of it. And I think, again, that's partly to blame for a little bit of a hierarchical system that we've got in our industry. There's a lot of exceptional experience out there, but just because they're experienced doesn't mean they're right all the time. And I think it's good that you say that even the experienced and well-respected therapists get questioned and get critiqued.
Do you think that elusive why is something that you've chased throughout your career, or was there a moment in which you felt experienced enough to start being more brave, shall we say?
Oh, definitely. Well, yeah, I think I've always been a contentious bugger. I'll always, if somebody says that's black, I'll say, well, no, it's a different shade of black. It's quite grey, actually. So I've always been like that. But I think, as I say, I've become bolder as time's going on. I'm not now afraid to back down or to think, actually, I better not ask him. He's quite well respected. He's quite, he's got a PhD. Who do I think I am to question a PhD? But I actually think, no, they're the guys that I need to be questioning, because these are the guys that have probably got more brains than me and then can turn around and give me the answer, or not, as the case may be.
Okay. And at present, well, it's changing, but critique has often been called felt to be an academic process. So it threatens a lot of people. So Can we trust abstracts is sometimes something that I'm asked. And if we can't, then where are we finding the time to go scrutinising these journals?
No, you're right. You can't trust abstracts. You can't trust research, full stop. You've got to be looking at everything you read and listening to with a critical eye and a critical ear. Again, another skill that's needed just as much as critical thinking is being able to evaluate and research. So, having to be the skill to look at a research paper, to structurally critique it, is something that should be taught. It is taught at university, but again, I don't think the emphasis on there, and I don't think the time to do it. I'm still learning. Statistics make my brain bleed. They drive me crazy, working out, confidence intervals and kappa coefficients, but they are essential skills that I think every practicing clinician needs to be able to interpret. It gets easier the more you do, but I think if you can't critically evaluate a paper and you can't use your skills to go through a research paper and decide and make up your own conclusions rather than listening to the conclusion that's actually on the paper, I think I use a little terminology. I like one-liners, but I say a therapist that can't critically evaluate a research paper is as underprepared as one that can't identify red flags.
Okay, wow, and that's a big statement.
Yeah, I definitely do think. I know it's a bit grandiose and it's a bit dramatic, but I do think they are just as important in this. That's how much emphasis I place on being able to, research and being able to read research effectively.
And that's a fair opinion, Adam, but an argument would be that missing a red flag could be life or death, and an inability to critique might result in simply a misguidance of a patient. So is that an example of a 140-character sweeping statement, or is it one you can elaborate and justify?
Yeah, possibly it is one of these melodramatic statements that you have to put out in a sort of a limited character space. Yeah. But I think it's these sort of short snippets that are a little bit over the top and melodramatic that do get people's attention. And do get the comments and the debate and the discussion going around such an important topic. I think, as I say, being able to critically review, may not be life-threatening to a patient, but it is an important area that we do need to, as a profession, improve on. And I do think, as I say, controversial tweets do get attention, they get retweeted, it gets out to a bigger audience, and so that the attention and the information can get disseminated across a wider audience. And actually, I got the idea from a statement that was in the BMJ. But in 2008, they posted an article that had the same comment in. They used it from a doctor's perspective, saying that a 21st century clinician that cannot critically read a study is underprepared as one who cannot take a patient's blood pressure. So they used the same tactic that I used. So, I think, as I say, it could be argued that it is over the top and melodramatic, but it does grab people's attentions and it does get the debate and the discussion going. And I do stand by it. I think, as I say, we are lacking in our ability to critically review research, and I think that's why there's so many dubious and poor treatments that continue to date, and it takes a long time for that new clinical or evidence-based practice to come out into clinical practice. I think I read a paper somewhere that takes about 17 years for something to... I know, it's a long, long time. And I think it's because people don't read the research critically and don't take things on board.
Wow, okay. But what makes a constructive critic, and are you one?
I'm getting there. I think so. As I said at the beginning, I do make mistakes. Everybody does. To be a constructive critic, you need to be able to, do things concisely. You need to be able to form questions clearly and precisely. I'm getting a little bit better, although listening to this podcast, you might hear my voice is probably not that best at being that clear sometimes. And the other part of being a good critic is being open-minded. You've got to be able to, take difference of opinions. You've got to be able to assimilate those opinions. You've got to be able to, filter through the information. And again, I try to be open-minded, but there is some stuff out there that is just so beyond my realms of understanding or willing to understand that I do sometimes close the gates, rightly or wrongly. But again, there is a lot of quackery out there. So whether people say I'm closed-minded because of that, that's their decision. But no, I think to be a good critic, you've got to be open-minded, you've got to be able to formulate opinions concisely, and be able to construct an argument. That's the other thing as well. If you're going to critique something, you've got to be prepared to stand back and stand and defend it. So you've got to be able to, say, as I've mentioned before, use your debating skills to be able to defend your critique.
No, lovely. And whether by accident or not, you have found yourself in a position as being quite an eminent voice these days. And does that mean that would you consider yourself pro-physio as it is, or are you more pro-physio as to what it can be or what it could be?
I love the physiotherapy profession, first and foremost. I know, I have been accused of that, of bringing the profession into disrepute and say not doing my best to promote it. I do. The physio profession I wouldn't have been in it for over 10 years if I didn't enjoy what I do. I love my job. I love interacting with people. I love making people feel better. So I am pro-physio. It needs to be better though. So it's got a long way to go. I want it to be something more than it is at this moment. I think so. That's to answer your question. I am pro-physio. I think I'll be even more pro-physio given it a few more years' time.
Brilliant. And you meet opposition not just because of your critical thinking and your provocativeness, but often just because you are challenging some of the historic norms that people stand and hold so close and dear to them. So what makes physio inherently, or not just physio, but healthcare, so inherently defensive, do you feel?
That's a good question. I don't know is the simple answer. I think there's probably an undercurrent of, again, fear of asking difficult questions that sometimes don't have the answers. So instead of going down that route, they'll be a bit defensive about things. So I don't know is the simple answer.
Yeah, one day maybe find out. Maybe. One tweet at a time. I regularly get pulled up. I haven't been on Twitter long, okay, quite the amateur compared to your thousands, but I get pulled up regularly by suggesting a level of both accidental and purposeful dishonesty in the industry. And am I fair to suggest that, or does everyone mean well and opinions simply vary?
Again, I think there's a bit of both. As with most things in life, again, I'm beginning to learn that if you look at one extreme of an answer and then the other extreme of the answer, the truth normally lies in the middle. And so I think there are people out there that are dishonest and will make up rubbish to sell a procedure, to sell a method, to make money out of it. And then there are people that are just poorly informed and making erroneous decisions based on misinformation or misinterpretation of information. So I think you do need to try to educate, and that's exactly what I try to do. When somebody thinks they're doing something which is just totally rubbish, I will say, hold on a minute, no, that's not quite right. And then gauging from the response that you get, then you'll decide, if they are being genuinely dishonest or they're just poorly misinformed.
In today's day and age, with the options and opportunities that are out there and free resources, is being ill-informed good enough at this level?
No, it's not good enough. But I understand that there are people that have more time on their hands to be better informed than others. It's tough, as you say, trying to get the time to read all the research, to be able to assimilate it all, to be able to critique it all. That there's reams and reams of information, being constantly churned out, and having to sift through that is difficult. And that's why we rely on experts to be able to assimilate this information and disseminate it and cascade it down to us. So I think no is the answer, simply that no, there's no excuse for it. I understand when it does happen, though, because of other circumstances.
Of course. And so that brings it on to probably the better question is that, are the likes of me and you instigating change at the right level then? Or does it need to go higher than that to free up that time?
Yeah, I think it's a good platform. Twitter and social media is a good platform to raise awareness, definitely. I think, if we keep shouting long enough, people are going to start to listen and hear. So I think that's exactly what we've got to try and keep doing. But you're right, it does need to go down at all levels. As I say, we've got to have a change of thinking, a change of understanding, and that's got to start right down from the clinicians' levels all the way up through to the universities, all to the researchers as well.
And so, universities, do you feel that undergraduate teaching is setting us up for the same problem year in, year out? Because, it's been said non-clinical staff form the majority of teaching staff at most major universities in this country particularly. And does that contribute, do you think?
It has an effect, definitely. But I think, I have had experience of lecturing at Brunel University. I have, experienced it from the other side of the coin. That they're in a tough position as well. They are to blame. I think some of the clinicians and educators in some universities are very stuck still in the 90s and the 80s and in this biomedical structural paradigm, and that is a factor. But I also think there's many universities out there that are trying their best to lead from the front and strive. They are restricted with time constraints. You've got a lot of information to give to a student within 3 years. They've got to get their clinical placements done and dusted as well. So it's difficult for them. They're stuck between a rock and a hard place. They can't give a therapist or an undergrad therapist all this information because it will just absolutely, overload them completely. It has to be drip fed. So I think it's a difficult question to answer.
Yeah, and particularly with the 3 years, it's not just covering our field, which is musculoskeletal and sports physio. So would you say that might be the future, is that we start to potentially specialise degrees?
That's a great question, and it's one I haven't thought about, actually. But now that you mention it, I think that's an exceptional idea. There will obviously still be some physio students that are unsure about where they want to go, so that could limit them with regards to their career choices. But that's a great. I never thought about that.
Fair enough. I should have maybe prepped you then, shouldn't I?
Let's market it and let's go to a university and we'll say, okay, here's a musculoskeletal physiotherapy 3-year degree. There's a respiratory physiotherapy degree. That's an exceptional, but that's a very good point. Something that
I might not put that out there then. All right, we'll keep that one to ourselves. But we would say that there's always going to be crossover as well. We know, we can't put his musculoskeletal hat on without keeping particularly our neurobrain going as well. So I suppose we wouldn't separate everything, but yeah, maybe an idea for the future.
Yeah.
Of all the topics that I've witnessed you debating online, a common theme seems to be your dislike for over-treatment, especially when it comes to passive modalities or therapies. What's led you to forming that as a pet hate, would you say?
I think it's my own personal experience of, one, being taught all these passive treatments, but also, seeing patients coming to see me that have had passive treatments from other therapists time and time again, and seeing how ineffectual they are. Again, I don't want to get into too much of the debate about whether we should be doing passive treatments. There are some benefits, there are small benefits. It's a case of, it is a pet hate when people overuse passive treatment because of financial gains. So there's a lot of profiteering, I think, out there with a lot of therapists trying to, keep hold of clients, keep them coming back, taking away their internal locus of control, making them feel or realise that this is treatment, is what's going to make them better, is what's going to make them feel better. So I think that's what's developed my hate of passive treatment. I use passive treatment. As I say, I don't want to negate the effects of passive treatment. They do things. They don't do the things that a lot of therapists think they do, from a mechanical point of view.
So would you say it's more your problem or your beef would be with how it's sold?
Absolutely. Sold as in financially sold, and sold as in, the answers sold to the patient. They're definitely.
Okay, on manual therapy then, without us wanting to delve into this hands-on, hands-off debate, which most of them, I guess, have disliked that. It's not clean-cut like that. But do you think that we can passively, mechanically influence tissue? So either articular through mobs and manips, or soft tissue through massage or myofascial release, for example. They're very common passive techniques, but what do you feel we're doing?
Mechanically, nothing. So categorically, no, I don't think you can, do anything to the tissue mechanically. Simple answer. When I say you can't do anything mechanically, all tissues are viscoelastic, so they do deform under pressure. And yes, there are some tissues that deform with pliers force through our hands, but very, very, very minimal, and for fleeting, brief fractions of a second. So, I'm not negating the effects of viscoelastic properties of human tissue, but, the effects of manual therapy applied in a 30-minute session is not going to last. And that goes the same whether you're doing a fascial release, sports massage, a joint manipulation, or any other sort of passive treatment. So there is no mechanical effects to any manual therapy. It is all neuromodulation.
Okay, and so sometimes that becomes the change of excuse almost, that okay, if we're not affecting it mechanically but it has worked, we'll just go neuromodulation and physiological, and we'll throw down that and not change much. Does that sit well with you?
No, I don't think it does either, because it's still passive treatment. It's still, at the end of the day, not addressing the issue, which it could be, as I say, down to the fact that they're not active enough and they're not moving properly. So it certainly doesn't. As I say, whether you're using a neuro explanation or a mechanical explanation, at the end of the day, it's still passive treatment.
Okay. And as part of this process, we bounce a few articles between us to make sure that we're on the right page, and some of the ones that you've shared with me are some golden oldies that you feel have been lost in translation a little bit, or hidden, or
forgotten about. Yeah, definitely much. So again, everybody has this aversion to reading a paper that's over 10 years old. They think they have to read the latest current research, and you do. But, we've got to remember the lessons from history. And they say there are papers out there that are, as I say, are absolute gold. And they just get totally forgotten about. And they're sort of hidden away. And they're like these little gems that pop up. And people will say to me, well, you're putting that paper, it's 25 years old. It still shows a point. And it is from this sort of ruling out of this mechanical, structural point of view. So, the talk that I did today over at the Sports Exercise Medicine Conference, very much, bringing up these olden papers that show, when a therapist feels that they can feel for stiffness in a spine, they can palpate down through a vertebral joint and interpret that movement as being either stiff or loose, is nonsense, because of the variability in forces being applied from therapist to therapist. The one paper I presented back from 1992, Harms and Bader. Two great names for physiotherapy researchers, by the way.
Harms and Bader. Definitely.
But the research that they showed that the mechanical forces, the variation in forces applied from therapist to therapist vary greatly. You've got some therapists only pressing at 100 newtons as they palpate the spine, some pressing up to 350 newtons. Wide variations in forces. So any interpretation of how stiff a segment is just down to individual perception. No reliability there. Now, some will say, yeah, but I can get a bit more experienced and I can tell, the more spines I feel, the stiff ones from the wrong ones. Well, again, the other issue there is the variability in individual stiffness from spine to spine. And I'm not going to get into the debate as to whether stiffness is an issue in back pains or not. There is research to show both camps or both sides of the story. But, the variation in forces applied through mechanical manual therapy is variable, and it is small. We're not going to actually create any changes in force. And another paper I like and I regularly post out there is Threckreld's paper back again in the early 90s, showing the actual, deformation forces needed to actually, change tissue is well beyond what we can apply with our hands and our fingers. Dump truck, maybe, you attach a patient to a dump truck and get them to stretch out. I don't know if that's going to be in the latest therapy.
Not done that in a while, no.
No.
Okay.
It might be a therapy later on down the line. Dump truck therapy.
Yeah,
start stretching the patients out.
Again, we shouldn't put that out there. This should be keep it under our hat. But, and then, so I would say that would be more of an articular manual therapy or passive therapy. If we would then say soft tissues. You've always had a bit of a beef with maybe trigger points and things like that. So tell me about your latest reading on that. Yeah,
trigger points, again, another area that does have some sort of palpation realms of fantasy addressed around it. So I think, looking for these tender spots in soft tissue, all well and good, but trying to find the knots and the taut bands and the twitch responses and everything that these trigger points are being described as being this sort of sustained contraction within the muscle is not something I believe in. I mean, I've palpated a lot of soft tissue in my time, and I think I can put my hand on my heart and reliably say I don't think I've ever felt a true trigger point. I don't think I've felt a knot in a muscle. I felt certainly lots of sore spots in people. I felt people that are guarded and tense because of pain, but trying to find a trigger point, I don't think I've ever felt. So I might get a lot of criticism for that. I'm sure I will. A lot of people will say, well, you haven't developed the super duper feely extrasensory perceptive hands. I'm sure you've got a few of those. Okay? But it's a case of the research shows that, when it comes to palpation of trigger points, we're very, very unreliable. And this goes back to again, in the early 90s, another golden oldie. Even the world's experts, and we're talking even David Simmons of Travell and Simmons, unable to reliably palpate trigger points in a study done by Fred Wolf back in the early 90s. just that it's so unreliable that to try and feel for a knot or a taut band, and again, it's very mechanistic. It's very, this is, where the root of your problem is, and this is what we're going to do, and we're going to poke this muscle better, and we're going to stretch this muscle better, and there you go, all your symptoms are solved. Well, why don't we go a little bit deeper and look at, well, why is that muscle sore? What's going on there? Is it getting overloaded? Is it getting grumpy because of something else? Is it, a neural problem? Is it even a muscle that's causing it? I mean, the research I'm reading about it at the moment on the cause of pain, say especially soft tissue pain, predominantly all based on neural issues rather than sort of mechanical knots in muscles.
So when it comes to these palpating of these tender spots that you've felt on people, and do you feel that sometimes you meet different levels of resistance within a muscle? Do you have an opinion on what that might be, or?
I think, again, it can be just normal anatomy. Lots of people, I mean, the classic one is in the upper traps. People say, I've got this knot in my upper traps. And you go, well, no, I think that's just the sort of medial pole of your scapula. And I think that's a muscle attachment on there, which I'm pressing quite hard, which feels sore anyway. No, that's definitely a muscle knot. So I think, feeling across human bodies, as say, it could be just normal anatomy that we're palpating. We're going from different, planes of fascia onto different muscles. So being able to feel a trigger point, no, I don't think it's, say, doable.
And that's something I think we'll probably come to in a couple of questions' time, really, is that becomes another thing, is us trying to normalise people, tissues, whatever we might be, trying to bring people to this middle ground that doesn't happen realistically in biology. But why as an industry are we finding it difficult to move away from this as a paradigm? And is it patient perception, as you've sort of mentioned, or is it because people say, well, it works and it has worked for me for years? Is that the main argument?
I think it's one of the arguments, definitely. I mean, there's that confirmation bias from both the patient and both the therapist. So I think, there's definitely both sides of the coin there. When somebody can see something works or feel something works, the buy-in's there. But then that's the neurological side of it. The fact that their brain feels that this is going to reward them. They're going to go and see a therapist, and this therapist is going to do this technique. It's going to make it better. Already starts off this neurological, I think, effect, the central neurological effect that say that this technique is going to work.
And if people will pay, then people will do.
Exactly right.
And that's unfortunate across a lot of industries.
I'm afraid so.
So what we've been listening to today at the Birmingham Sports Exercise Medicine Conference is saying that maybe in the absence of pain, palpating for diagnostics does fairly poorly when it comes to research and even in practice from what you said. But where's the line in the sand? Because surely we can trust our hands sometimes. For example, the Lachman's test, one of the most sensitive and specific in the industry when it comes to orthopaedic tests. And it has no painful positive. So surely that we can trust the laxity we find there. So what are your thoughts on that?
Yeah, that's a good point, Jack. I think the point I'm trying to make with diagnostic palpation is the subtle tests that are used without any clear history or mechanism of an injury. So these diagnostic palpation tests where they're looking for subtle misalignments or increased stiffnesses or even subtle increased laxities, we've got to take a critical view of what we can actually feel with our hands. As you say, there are joint laxity tests like the Lachman's out there that are specific and reliable and don't rely on a pain provocation response. But when you're doing a Lachman's test, there's normally a reason for you doing a Lachman's test. There's a clear history and a mechanism of injury somewhere in the background. You're 90% certain you're going to find a positive because of what you've gained from the subjective. So that the test is used to not sort of go searching for a diagnosis. It's used to confirm your diagnosis. These other diagnostic palpation tests that are used regularly in therapy, it's almost the opposite. It's going searching for a diagnosis by using your powers of palpation. And I think that's where the line in the sand has to be drawn. I think, as I say, we need to be able to use the diagnostic palpation tests to confirm a finding rather than going searching for a factor or a cause that we think may be causing this patient's pain. And there's other tests as well. The Lachman's is just one of the joint laxity tests that could be used as a good example of reliability. But there's others out there. You've got the apprehension tests as well. Technically they don't use pain, they use apprehension. And they're diagnostic palpation tests as well. So I think you could say that the shoulder apprehension tests are the same sort of situation.
Yeah, and I mean, it's very much in line with a lot of the guests that we've had on the podcast to date, is that there's a number of factors that we can play a part into a clinical reasoning process, but we just don't hang our hat on them and assume them to be the panacea that's going to tell us how to get this person better.
Exactly, and I think there's always an exception to every rule. My talk was obviously a little bit controversial. I suppose the pendulum could have swung too far in one direction. You have to find the middle ground, but I think diagnostic palpation that goes searching for a diagnosis by feeling for things isn't the way to critically reason or clinically reason. When somebody's walking into your clinic in pain, you have to use the subjective history, the clinical tests, the palpation tests, all in conjunction. And I think, as I say, what I was trying to get across is that people use the diagnostic palpation tests way too much and rely on them way too much when the research and the evidence doesn't back it up, nor does my clinical experience.
Lovely. No, thanks a lot for elaborating on that. And would you extend that to sort of muscle tone? So palpating, let's give a broad example of saying that someone's paraspinal muscles, if you had them prone on the bed and you were saying that potentially you had a higher tone or tension to the right side of the erector spinae than the left, do you feel there's a place for it, or is that just again getting to intricacies?
Yeah, I think, if you're talking really obvious, spasm, but you'll notice that from the way the patient moves before you even start palpating them, that they can't bend because they've got so much tightness and spasm and pain. So, why do you have to go poking those muscles to confirm what you already know, which will probably be sore for them? But no, this subtle differences in tone and tension and tightness that you poke and press around, again, use the old trigger points and the knots examples. There's no reliability in identifying different subtle differences in tone and tightness, or knots or lumps or bumps that could just be normal anatomical variation or nothing at all. And cause and correlation effects, is the tension because of something else elsewhere, and that's even if you could feel it. But no, I think, as I say, you'll tend to know before you even palpate diagnostically what you're going to find. That's when the reliability of the palpation test comes in, is that it's used to confirm what you probably already know. You don't have to go searching for it.
Yeah, and that's a point that's often made, is that some of the studies that assess even the reliability of things like Lachman's usually come off the back of a story, and the story can be as reliable as the test. So yeah, thanks for that. Okay, and so as one paradigm drifts out of fashion, another can come in, and the biomechanical normalising a movement is as popular as passive interventions, it seems. It seems that probably that's the worst thing in combination in some ways. It'd be a passive treatment that's then given a very biomechanical specific rehabilitation regime off the back of it. So two evils in one. Why does that not sit well with you either?
Again, it just totally negates the neurological system. It doesn't involve the brain. It's looking at just the meat and the structure. So again, I'm not a fan of any paradigm. Again, I know that the biopsychosocial paradigm is very good, but it's just one paradigm. We can't go to one way. We can't just go central nervous system, brain, etc. We've got to think of the mechanics from time to time. So I think, as I say, I'm not a fan of one paradigm over another paradigm. I think we need to take the best bits out of each one and add them together. So it needs to be a combined approach from various different paradigms.
And where would you say that it falls down the intricacies of, say, kinetic control, or trying to make someone move perfectly or normally?
It takes the patient out of the equation. It takes their consciousness out of the equation. So you're asking somebody to do something that you want them to do, and not asking the question to say whether they want to do it. And you've got to understand as well, patient, may not be, thinking of the task properly as well. So is that bad kinetic movement due to the fact that the patient's attention is elsewhere? We don't ask those questions of physiotherapists. We look at movement, we see a movement, and we say, right, that's not looking very good. But we don't ask the deeper questions. We don't think, is there, something else going on there with the patient's psychology? Is there something that their attention is elsewhere? Is it the environment that they're in as well? It's all these questions that I do find myself going down a bit of a rabbit hole. The more I constantly keep asking myself somebody to perform single leg squats, the classic. I'll get somebody to perform a single leg squat, and I'll see them do it badly, and I think, right, okay, that's internal rotational movement of the hip. I need to do the glute, and then I'm thinking, well, maybe it's because I'm watching them. Maybe it's because I'm sitting there. Maybe they're nervous because I'm watching them. Maybe the air conditioning's on too. And then all of a sudden, all because I'm thinking of the other factors, it's opened up this rabbit hole. So I do sometimes take biomechanical screening tests and kinetic control and movement tests now with a big pinch of salt.
Okay, so yeah, it's not trying to fit someone into a specific thing that you want them to do.
No, I use biomechanical screening tests. Okay, we've got to start somewhere. We've got to look at it. Okay, we can't just totally not do anything with them. But the questions are always in the back, and this is going back to this feeling uncomfortable situation. I feel uncomfortable with every sort of assessment I do. Am I going down the right pathway? Have I decided on the right course of treatment? Because, my brain is constantly thinking, what if, what about this, all these other factors. And I don't think many therapists do that. They think they see something, they'll go, okay, well, let's fix that. But my brain now, and that's probably Twitter's fault because it's expanded my knowledge into other areas and opened up other doors. But my brain now, as I say, when I'm assessing things musculoskeletally wise, is constantly feeling uncomfortable with what I'm seeing because I say I can't make any firm decisions.
Oh, fantastic. And so I think it's something me and you have debated ourselves on Twitter, is that once you then get pain into the mix, which is the primary reason a lot of our people or athletes or any patient comes to see us, that then changes things as well. Antalgic movement, we can't then scrutinise purely the mechanics.
No, we got to consider pain in everything we do. As you say, everybody that comes to see us, 99% of the time they come to see us, they're in pain, they're in discomfort. So yeah, we got to take that consideration of pain affecting the movement and their sensations of movement as well.
Okay, and critics of a research-led evidence-based practice approach to things would say that patient values and therapist experience can bring at least as much to the table as the literature. Is that a fair point, or is it an excuse?
It's a fair point. It is. I have one of my favourite sayings that I've been saying quite a lot recently, that your interaction outweighs sometimes your intervention. So yes, it's how you connect with a patient can have massive effects, but that still doesn't, give you an excuse to say, well, it's all, this. We've still got to follow evidence. We've still got to follow evidence-based practice.
And interaction over intervention is research supported, isn't it?
Yeah.
That's what's the
very much so. Yeah, you're looking at the main outcome of your therapy has been researched, and the biggest variable tends to be the therapist.
And we still work on interventions over interaction. Do you think that's the biggest pendulum shift? Really, is that we're going to chase our communication abilities and improve as best we can in those? Yeah,
that's I think, again, an area where it definitely needs to go. So research into intervention still needs to be done, and that has to be looked at and addressed. But again, there needs to be, and there's growing evidence and there's growing work being done into interactions. Look at the likes of Pete Sullivan's work, and obviously the stuff that Mike did in the last podcasts. All great stuff. All say showing that this communication skills and how you engage and interact with a patient is essential and vital.
Lovely. And if, as we've discussed in a variety of different topics today, if change is long overdue, what is it we're scared of?
I think when it comes to change, that a lot of people are scared of the risk involved. I think, there's always that fear of, are we doing the right thing? Are we going the right way? I think, a lot of people sometimes, mentioned before, get into their comfort zones and are happy to stay within there, and it feels cosy and warm. But where the magic happens is normally outside your comfort zone. And I think, as I say, as a profession, we've got to look to move out of our comfort zone. And look to expand and move with the times. And I think, various different modalities and methods, as I say, of doing that are on our laps, and we can look to utilise those. And Twitter and social media being one part of that, and the dissemination of information via those channels.
And so if we can evolve as a profession, we can better ourselves as clinicians, interactions between us, and fundamentally make it a better experience for our patients.
Exactly right. I think, the more informed and the more educated a clinician is, the one person that's going to benefit is the patient in front of that clinician. And I think, a clinician can become a better practitioner by, taking a lot of information from other practitioners. It's how we learn, it's how we develop. And again, social media and all these other things and these other avenues now that are opening up to us should be utilised more, a lot more, and we should be looking to use them and integrate them into practice as best we can do. I think there is a bit of an aversion to technology within physiotherapy. I think there's a lot of sort of old school, thinking with regards to, no, that Twitter stuff, as we mentioned at the beginning, Lady Gaga's and Justin Bieber's. But I think it's a fantastic tool and something that should be utilised.
So Adam, thanks a lot for your time today. Really appreciate it, particularly after a long, heavy conference. But if people want to hear more from you, where do they go? And also, have you anything that you want to plug for the future?
Well, obviously, people can come and find me on my favourite social media site, that being Twitter. So that'll be at Adam Meakins, and that's Meakins, Meakins. I have my links to my blog page up there, which is thesportsphysio.wordpress.com. It's about to be turned into a fully fledged website soon, I hope. I just got to get my arse into gear and get that sorted. So those are the two main areas where people can come and interact with me. And as I say, I really do relish the interaction with therapists and of all therapists, not just physiotherapists. I think that's another issue. I think a lot of therapists are scared to interact with interdisciplinary things. But I think, again, osteopaths, chiropractors, sports therapists, soft tissue therapists, the more the merrier. Come and interact with me via Twitter and find me there. I have a course coming up, which is a shoulder course down in London. So I've got an interest in dealing with shoulder problems, and as I say, I'm quite heavily involved in the management and treatment of shoulder in my day-to-day practice. So if anybody wants to come down and sort of have a few myths and misconceptions dispelled about how to assess and treat a shoulder, I have a course run over at the OMT training, which is a website you can find on Google. And that's it.
I'm sure we'll be talking about all of those things on Twitter sometime soon.
Sure,
so
I'll be tweeting them regularly.
Lovely, thanks a lot. And again, really appreciate it. And or maybe at some point we'll be called to action, have to come and answer to some of the things we've talked about today, and maybe in the future we'll chat again.
Great, awesome. Thanks for your time. Are you going to play that dodgy 1970s porno music now then after?
Well, now. So there's session 7. Many thanks to Adam Meakins for spending some time to natter with me. A particularly humble and public-spirited bloke. Now I've got to meet him, sometimes misunderstood, but definitely offering an awful lot to the physio community for free in his own time. So many thanks for what he does and also for his chat today. Hope you've enjoyed it. And as usual, you can find us on Twitter at choose_health, and the podcast team tweet from at TPM Podcast. Obviously, the sports physio, our guest today, Adam Meakins, is at Adam Meakins, all one word. We often get tweeted or emailed some kind words and reviews, which is really helpful, but please do pop them down on iTunes or on any of our podcast directories. That helps to boost our ratings, gets us more listeners, and helps us our voice to be heard far and wide. So as I hand the mic back over to Adam Meakins for our legendary, now famous sign out, please note that he, even after take 3, still couldn't get it right. Bye from me for now.
You've been listening to the Physio Matters podcast, discussing physio matters because, long dramatic pause, physio matters. Any more fromage and I'd be a Frenchman.